This one? Okay. So good morning, everyone. Let's start with the lecture for today. We will see, maybe just to revise what we have done yesterday, we have seen with the various phases of ovarian phases, that is the follicular phase, that we have seen that a woman undergoes 2 phases of follicular cyclicity every 28 days. The first one is the follicular phase, the other one is the luteal phase. In the follicular phase, there will be development of follicles, the dominance of the follicles, and then in the middle is the ovulation, and then starts the luteal phase, where the corpus luteum will be formed to produce progesterone and estrogen during that time. So, parallel to these ovarian phases, there are these events which are associated with dominance of the follicle. After dominance of the follicle, then there will be LH surge, which induces ovulation, and after ovulation, the corpus luteum will be formed to produce estrogen and progesterone. Parallel to the ovarian events and phases, we have the endometrial events, which are mainly associated with variations in the thickness of the endometrium. That means the endometrium varies depending on the stage of cyclicity, that during the menstrual bleeding, the endometrium lining is very low, and then afterwards, through the action of estrogen, we have the proliferation of the endometrial cells, so that the thickness of the endometrium will be larger compared to the time points of the menstrual bleeding. So the phases of the endometrial phases during this cyclicity is divided into 3 phases. One is the menstrual bleeding site, that is the date 1 to 5 mostly, and then starts the time points of proliferation, where estrogen is acting so that the endometrial epithelial cells will be proliferate, and the thickness of the endometrium is increased, and then through the action of the corpus luteum at the time points of the luteal phase, then through the corpus luteum produced progesterone and estrogen are able to act on the endometrial epithelial cells, so that they can produce different types of glycoproteins, which makes the endometrial environment hospitable for the growing embryo. So these are the phases which we have seen yesterday. Today we will be trying to see how embryonic development after the syngamy of the sperm and the egg, how pregnancy is established, and then after the first phase of embryo development, there will be implantation of the embryo in the endometrium, and then 9 months later, there will be parturition is initiated, so that the birth of the baby will be possible. And then after parturition, after the baby is born, then there will be milk production, milk secretion and injection from the breast. And how that will be regulated, we will see in today's presentation or in today's lecture. Just to start with, we see here how zygote is developed, starting from the time points of ovulation from the ovary, and goes through the mouth of the fallopian tube or the oviduct, and then here the place where fertilization takes place, when the sperm goes through the vagina, through the uterus to the site point of fertilization, the site of fertilization, and then the zygotes will be formed, and this zygote will develop to different stages of development in the reproductive tract of the female. Just to remind you, the first 2 or 3 lectures, that ovarian gametogenesis takes place in different stages of follicular development, which give rise to the ovulation of a matured oocyte, that is the secondary oocytes, having the diploid nucleus here and one polar body. Then these the secondary oocytes will undergo its meiosis, secondary meiosis at the time points of fertilization. That means when the fertilization takes place, then we will see that the nucleus of the secondary oocytes will be divided into two, and then one of them is the secondary polar body, which is extruded here outside of the cytoplasm. And these are the two polar bodies, the first and the second polar bodies, which were arised due to the two meiotic divisions happening in the oocytes. So we have the pronucleus of the egg, we have the pronucleus of the sperm, which will unite together to form the so-called the diploid zygote. So this zygote will develop, so depending on the time, mostly it is 24 hours later, it will divide into two cells. That is called the so-called two-cell stage. The two-cell stage is having two divided cells, and each of these cells are called the blastomeres. So the cleavage period goes further from two-cell stage to the four-cell stage and goes to the eight-cell stage. And then at the time points of the morula, that means 72 hours after the fertilization of the egg, the embryo starts to leave the oviduct and goes down to the uterus just to implant. So the last, up to this stage of development, up to this cleavage stage of development, the cells are called totipotent. That means that each of the cells have the capacity to develop to individuals. That means the cells can be developed to individuals. However, when the embryo reaches to the side point of blastocyst, it's called blastocyst, the cells, the blastomeres are differentiated into two different types of cells. The one is the inner cell mass, the other one is trophectoderm cells. Normally this is called ICM, inner cell mass cells, or trophectoderm cells, normally TE cells. So the blastocyst is having such kind of structure where we have cells at the edge of the embryo are the so-called trophectoderm cells, these ones. And then there is another clump of cells here and somewhere here. They are the ICM, or the inner cell cells. So this is a kind of fluid-filled blastosole. And the trophectoderm, or the inner cell mass cells, these cells are the ones, after implantation, are the ones which are becoming the embryo. But the trophectoderm cells, the TE cells, which are found here around, are the ones which are becoming the placenta. So these are the two specialized cells at the blastocyst stage before the embryo, which are developed before the embryo implants in the uterus of the mother. So there are some rare cases where embryos are embedded or implanted in the fallopian tube and develop here, or in some cases, instead of going into the uterus, some of the embryos are going back to the abdominal cavity. These are the so-called ectopic pregnancies. These ectopic pregnancies are very rare cases which are happening, and they are pregnancies which are happening outside of the uterine environment or outside of the uterus. In case of the ectopic pregnancy, which is happening in the oviduct or in the fallopian tube, is a very dangerous situation which needs to be surgically removed. The other one is when the embryos are coming back and fall into the abdominal cavity, and they are developing to a kind of stone babies due to the accumulation of calcium all around that embryo. So these both cases, the case of the fallopian tube implantation or pregnancy, both pregnancies are dangerous. They need to be surgically removed. So looking into what will happen exactly when the embryo is starting to implant into the uterus of a woman. If you are working in a kind of the human IVF clinic, or for example, in my case, which I am working with using the cattle embryos, when you look into the embryos under microscope, so they are exactly looking like that. So they have a structure called zona pellucida, which is surrounding the oocyte. Once fertilization happens, you will see here two dots, which are showing the sperm pronucleus and the egg pronucleus, and the two first and second polar body are also shown there. So they look exactly like that. This is the zona pellucida, and then after certain time, 30 hours after IVF, then they divide into two. They divide into two, and these are the two blastomeres of the 2-cell stage, and then again they divide, and we have the 4-cell stage here, embryo development. The 8-cell stage and goes to the 32-cell stage, and there is the so-called a morula stage. A morula is a stage where the cell-to-cell communication between the blastomeres is highly intensive, and they compact together before they expand to the blastocyst stage. This is the blastocyst stage. Transition to the blastocyst stage, where we have here, this is a cell which is called the inner cell mass, and the trophectoderm cells are the ones which are found here around. Then at day 7, it's clearly day 6 or day 7 of the pregnancy, you see a clear distinction between the inner cell, the trophectoderm cells around the blastocyst here, and then the inner cell mass, which is going to be embryo, is shown here. So this is just for you to see how embryo development takes place in the fallopian tube and later on in the uterus before the embryo is implanted. So these are stages of embryo which are called pre-implantation embryos. Maybe you have heard of pre-implantation genetic diagnosis, in which cells can be taken as a biopsy from the developing embryo, and diagnosis can be done on various aspects of chromosomal abnormalities or whatsoever diagnosis, what we call it a pre-implantation genetic diagnosis. So pre-implantation embryo starts from the zygote, goes to the 2-cell stage, goes to the 4-cell stage, and then comes 16 to 32-cell stage. Then comes the compacted morula. Then finally comes the blastocyst. So as I said before, the blastocyst is the time point or the stage in which the cells which were not differentiated before are differentiating into two different types of cell types: the inner cell mass, which give rise to the embryo, and the trophectoderm cells, which is giving rise to the placenta of the developing fetus. So how is implantation occurs? This is the first event in implantation is the contact between the embryo, the blastocyst stage embryo, and the endometrial cell lines here. We see here the inner cell mass here. These are the yellow ones are the trophectoderm cells. And the first contact will be established here, that is the endometrial line of the uterine wall, and the inner part is the myometrium. And the first contact results into the proliferation of the trophectoderm cells, which are in direct contact with the endometrial line. Not only because of their ability to produce proteolytic enzymes, which are able to, which allow the embryo to embed itself into the uterine wall, and there will be a higher degree of proliferation of the trophectoderm cells, which are in contact with the endometrium, and at the same time there will be also proliferation and modification of the endometrial cells, which are receiving or which are in direct contact with the embryo trophectoderm cells. That means when the zygote is developed to the blastocyst stage, and the blastocyst is the time points between day 14 and 20 of the menstrual cycle. That means we have seen that previously. This is the time. That is the time points of menstrual bleeding. And we have here at day 14 of the cycle, there will be ovulation. And then here's the time points of after ovulation. Then this is the time points where pre-implantation embryo development happens. That means from the zygote to the blastocyst stage. So in this case, once ovulation happens, under normal circumstances, the corpus luteum is established from the granulosa cells and the theca cells of the ovary, and this corpus luteum produces progesterone. That means the progesterone is very important for preparing, that is until day 25. We have here, there is high progesterone from the corpus luteum. So this progesterone makes the uterine environment very conducive for the embryo, because after 5 days, the embryo comes from the oviduct to the uterus. When it reaches to the uterus, then the conducive environment is possible because of the action of the corpus luteum. So this is how the implantation process starts and goes further. That we see here, that implantation of the blastocyst is so it's the same information, but what we see here is that the trophectoderm cells, which are found around here, are proliferating and penetrate the endometrium so that implantation can take place in the implantation site of the uterus. Previously, we have seen that the corpus luteum after ovulation, that is the time points of ovulation, this is ovulation, the corpus luteum is established here and increase the amount of progesterone. This will happen only until 10 days of that is 24 days. 10 days of pregnancy, until 10 days after ovulation, that means until the 24th day of the ovarian cycle, the corpus luteum is maintained to produce more progesterone. This was possible because of the action of LH, which was higher here, and this acts on the corpus luteum not to regress. That means corpus luteum regression will be prevented until the 24th day, that means 10 days long after ovulation, because of the action of LH. However, if the action of LH will reduce, under normal circumstances, the progesterone level goes down because of the regression of the corpus luteum. However, when pregnancy happens, when there is an embryo in the uterus, the embryo trophectoderm cells are able to produce a hormone called human chorionic gonadotrophin, which acts on the corpus luteum not to regress. That means the production of progesterone from the corpus luteum continue to happen. So that is where we have a corpus luteum is rescued and will not regress, so that progesterone will be produced to promote the implantation in the pregnancy of that specific individual, so that in specific embryo. That means the embryo sends a signal to the mother or the maternal environment that there is an embryo which needs to be maintained, so it needs progesterone for a hospitable uterine environment. So that means the human chorionic gonadotrophin, which is produced by the trophectoderm cells, is the one which protects the corpus luteum from regression. So if the corpus luteum is not regressed, then there will be increase in progesterone production instead of going down and coming to the new cycle. Yeah? So that is very important for how pregnancy establishment is preventing the corpus luteum from degradation, so that a higher amount of progesterone will be produced from the non-regressed progesterone, from non-regressed corpus luteum. When placenta is formed, we see here the placenta has different structures. This is the side of the mother side, that is the endometrial side. This is the embryo side. We need to think that we have here the embryo, developing fetus. So the connection between the developing fetus and the endometrial side is performed through the action of the placenta. So the endometrial side has two layers. One is the endometrium, the inner side, and the other one, the outer side, is the myometrium. So the main contact between the embryo and the embryo and the mother is through the endometrium side of the maternal uterus. So these are the umbilical cord, which is connecting the fetus with the placenta. And there are different veins which are bringing, for example, umbilical arteries are bringing blood from the fetus to the maternal side, and the other one is the umbilical vein is the one which is bringing a new and oxygenated blood to the fetus. The very important here is that there is no mixing of blood between the mother and the fetus during the exchange of materials. So the semimembrane, the semi-permeable membrane of the placenta is allowing the retrieve of oxygen and nutrients through the action of the umbilical veins to the uterus, to the fetus, and excretes and carbon dioxide wastes will be removed from the fetus to the maternal side using the umbilical arteries. So this shows how the structure of the placenta looks like, which is developed from the trophectoderm cells of the embryo. So pregnancy progresses. We see here is that the cervix, so next to the vagina, and we have here a long uterine canal, and that is the first stage of the 3 weeks of pregnancy, that we have a small embryo here with some form of amniotic cavity here. The myometrium is in the upper side, that is the endometrium. And then when pregnancy is progressing, then we see here that the canal is getting shorter and the fetus becomes larger. And we have here the amniotic cavity coming from the inner cell mass of the embryo, and the chorion is coming from the trophectoderm of the embryo. That means from the trophectoderm cells. This is the site where placenta establishment is taking place in connection with the fetus. So developing placenta is getting larger and larger. So when we come to the 8 weeks of pregnancy, we see here that is a very clear phyllis of the various structures of the placenta are very clear, and we have the mixture or the connection of the chorion and the amnion cavities is happening. That means now this time the fetus becomes bigger, and there is a formation of what's so-called amniotic fluid in which the embryo or the fetus is swimming in. And you see here the cervical canal is becoming shorter and shorter through the progress of pregnancy. There are different ways how fetal diagnostic can happen. So fetal diagnostic can happen by taking different types of genetic material to investigate for the presence of genetic diseases in the developing fetus. So one of them is investigating different types of chemicals in the amniotic fluid of the fetus, or cells floating inside the amniotic fluid can be used to analyze, for example, the chromosomal abnormalities of that specific fetus, or the sex of the fetus can be determined using those cells in the amniotic fluid. And also, there is a kind of procedure where chorionic phyllis sampling can be taken, but this one is very dangerous and can lead to miscarriage of the fetus, because the phyllis are very, very sensitive areas to sample. Ultrasound, which is without any X-rays, are the most widely used procedures just to see how the fetus is developing, how the structure looks like. They can make different types of measurements to see age-associated increase in different parts of the fetus. Maternal blood can be investigated just to see whether there are changes in various hormones, or which can be associated with various types of abnormalities like the Down syndrome of the fetus. So these are the different types of fetal diagnostics which can be done during the time period of pregnancies. Let's see how the hormone profile looks like during the process of pregnancy. That is the time points, the start of the day, the months, that is a month, until the 9th, 10th month. So we see here that the first month, there is a significant increase in the human chorionic gonadotropin, which is coming from the trophectoderm of the blastocyst, as I showed you before. Means we said that corpus luteum regression is inhibited by the action of LH during the first first 10 days after ovulation. Then later on, the corpus luteum is the main source of progesterone, as I said, and estrogen during that specific period. However, if pregnancy happens, if there is no pregnancy, then the LH will be diminished, and the inhibitory effect of the LH will not be there. So the corpus luteum will degrade or regress. So then the progesterone and the estrogen level will go down, and because of the low progesterone and estrogen, estrogen, then the inhibitory effect on the gonadotropins is lifted. Then there will be the release of FSH from the pituitary, so that the new cycle will begin with the selection of follicles. However, if pregnancy happens, then the corpus luteum regression inhibition is overtaken by the so-called human chorionic gonadotropin, so-called HCG, secreted by the TE cells of the blastocyst, is inhibiting the corpus luteum, reducing or inhibiting the corpus luteum regression, so that there will be a continuous supply of progesterone and estrogen for to have a hospitable environment in the uterus. So that means initially the progesterone and estrogens are produced by the corpus luteum. Once the human chorionic gonadotropin is activated, then the progesterone and the corpus luteum will not regress and continue producing the progesterone and estrogen. However, there is a significant decline and starting from the third month of pregnancy, a significant decline of the human chorionic gonadotropin from the blastocyst or from the fetus. Then the corpus luteum is stopping to produce any progesterone, estrogen. From this time onwards, from the time points of decline in HCG, the progesterone and estrogens are produced by the placenta. That means this will be until third month of pregnancy, and then at third month, after the third month, the HCG declines, so progesterone and declines, and corpus luteum is no more there to produce progesterone and estrogen. From this time onwards, the placenta is the one which produces progesterone and estrogen. Progesterone and estrogen will be produced from the placenta so that pregnancy can continue. Without the progesterone and the estrogen, the embryo production, the embryo development is not possible. That means if somewhere the progesterone estrogen goes down, that means the new cycle begins. That means that specific embryo or pregnancy will no longer possible. That's why whenever we have, after the 3 months, the placenta takes over the duty of producing progesterone and estrogen, to produce, to have a very hospitable maternal environment in the uterus, so that pregnancy can continue. So normally the placenta has the necessary enzymes to produce progesterone directly. But the other thing what the placenta has is the ability, or the so-called the enzyme called aromatase, to generate estrogen from androgens. androgens are normally produced during pregnancy from the mother side and also from the fetal adrenal gland. So these androgens will be utilized by the placenta to produce estrogen, and the placenta has the necessary enzymes and everything to produce progesterone. So these two are the ones which are produced by the placenta. Through the progress of when pregnancy is continuing, and then these two hormones, the progesterone and estrogen, are dropping down at the time points of delivery. That means when they drop down, that means there is no placenta when the delivery happens, so the level of progesterone and estrogen will be lower, and this gives rise to the start of a new cycle after birth. So this is the hormonal profile, look how it looks like during the pregnancy of a woman for the 9 months period. So the other important event in reproduction is the so-called parturition. Parturition is a process of delivery of the baby after the pregnancy period. So the two important events, the first important event in the parturition is that through the progress of pregnancy and at the age of the age period, the 9 months period of pregnancy, there is a drop of the fetus to the lower of the uterus. That means there is a high level of pressure from the fetus or from the baby to the cervical canal, and this stretch is sending a signal to the hypothalamus, so that oxytocin is a hormone which is produced by posterior pituitary to initiate the contraction of the uterus. That means uterine contraction will be induced because of the availability of the oxytocin, which is induced by the cervical stretch of the pressure from the baby. And at the same time, this oxytocin is acting on the uterus to produce, so that the uterus produce prostaglandins, the hormones called prostaglandins. Prostaglandins are very important for inducing the uterine contraction so that labor will start. So this is a process which is going as a kind of positive lead back. Then finally, when this stretch and labor are getting intensive, then there will be a delivery of that specific baby through to the world. So that is the way how, so the pressure from the baby in the mother on the cervical stretch induces production of oxytocin from the anterior pituitary, and that also initiates the production of prostaglandin in the uterine wall. Both of them are acting on the uterus to start to relax and contract, so that there will be a delivery of that specific baby. So you may have seen somewhere in different textbooks, this is the way how, the position of the baby coming the head down lead to exert a pressure on the cervical cavity here. That will lead to the labor, which is pushing the baby through the cervix of the vagina, and that will lead finally the placenta will go out and detach from the uterus, so that there will be no production of production of progesterone and estrogen from the placenta, so that the one which we have seen, the curves which are going down, is because of the removal of this placenta out of the uterus during the delivery. So just to summarize, the one I said is that the beginning is that the fetus head is pushes downward and leading to the increase in uterine contraction, and also there is an action of this uterine stretch leads to the positive induction of the hypothalamus to produce oxytocin neurons to produce to act on the posterior pituitary to increase the secretion of oxytocin. This oxytocin will be released into the plasma or the bloodstream, and increase in plasma oxytocin will lead to the contraction of the uterus, and at the same time the other feedback, positive feedback, is the action of this stretch on the prostaglandin secretion, which is locally acting on the uterus to lead to contraction and later on to the delivery of the baby. I think we have seen already that one. That means after delivery, all goes down and a new cycle begins when the hormonal balance is maintained. So we have heard of different types of contraceptives to have a birth control methods that work prior to implantation. That means before the embryo implants, there are different types of contraceptives which are used for preventing the establishment of pregnancy before implantation occurs. Procedures afterwards are, after implantation, are called, these are so-called abortions, which are ethically very controversial, and this is the way how to protection of birth control before implantation or establishment of pregnancy, and here is the time points of abortion. There are three categories of contraceptives. The first one is the barriers, the so-called barriers. There are pills which are combination of progesterone and estrogen, but there are also some surgical procedures to have a contraceptive procedure or to protect the establishment of pregnancy. Barriers include both male and female condoms, diaphragm or cervical cap, which are normally put, plastic caps which are put in the that is cervix. They are put here just to block the passage of the sperm from the vagina to the uterus and to the fertilization site in the oviduct. And this is normally relatively low in efficiency. That means, so every year, those people, from 100 people who are using different types of these barriers, they could get pregnant 16 to 32% rate. So that means the efficiency of these barriers is around 70% in terms of preventing the establishment of pregnancy. So that the other one is the very widely used ones are oral contraceptives. These are called pills. They are mainly a combination of synthetic estrogen and progesterone. So this is mainly based on the inhibitory role of action of progesterone and estrogen on the gonadotropins. That means there will be no ovulation whenever we use or the lady used contraceptive pills, because the estrogen and progesterone are acting negatively on the gonadotropins, the FSH and LH. And if these are absent, that means no ovulation. So there are also different types of pills. One is the mini pills. They are mainly containing progesterone-like substance, but the way how they act is different than the other normal pills. They are not always inhibiting ovulation, but they change. These mini pills are changing the environment in the vagina or in the cervix. They are changing the cervical mucus composition. the cervical mucus composition will be changed in such a way that the sperms which are ejaculated during sexual intercourse are no more able to swim to the egg. With that, they are able to inhibit the fertilization of the egg by the sperm. So these contraceptives are, you don't need to worry about them, just for you to know how understanding the reproduction of female or male leads to the different types of contraceptives in the reproductive world. So the other permanent way of sterilization methods are vasectomy, which is the male type of surgical blocking of the vas deferens to prevent the sperm getting into the seminal fluid. We have seen during male reproduction, we have seen that during male reproduction, we have seen that there is a testis with epididymis. This is the site of production of the sperm, and from the epididymis goes from vas deferens, that is the vas deferens, for transport of the sperm to the seminal vesicle, where the fluid part of the semen will be produced, and then this fluid will be going to the ejaculatory tract and goes to the penis and coming out as the semen. The technology of vasectomy in male surgical blocking is the blocking of this canal. If this canal is blocked surgically, the sperm which is produced here cannot pass through and come to the fluid which is going to form the semen. That means the male can normally produce or ejaculate, but they are ejaculating only a fluid which has no sperm. The other way is the tubal ligation in the female. That is the same thing, that we have the ovary here. This is a fallopian tube. So this will be ligated here. The ovulated oocyte will not come through that one. So there will be, the sperm can get into this, but there is no oocyte which is reaching to the point of fertilization. So these are the two types of surgical procedures, but there is also another one called spermicides. Spermicides are chemicals which can apply in the vagina so that the sperm which is ejaculated during sexual intercourse will be killed by these spermicides. So the spermicides are killing the sperm in the vagina so that there will be no sperm which is going from I will skip the other one and then I will show you here. So this is the time in the structure of the breast of a woman. We see here that is a nipple. From the nipple there are different branches of a kind of alveola which are going to this one. This is the site point, the site of the milk production. So these alveoli are developing in different stages of development. Prior to pregnancy, there are only few ducts here. So during early pregnancy, alveoli are growing through the action of progesterone. Progesterone is acting on breast growth, and then the middle of pregnancy, we see here a very large amount or alveoli. Then during lactation, there will be huge and very filled alveoli dilate here. So once weaning takes place, so there is no milk production, on this alveoli are getting smaller and smaller. So at puberty, estrogen increases the duct growth and branching, and progesterone promotes the alveolar growth. Pregnancy is, during pregnancy, estrogen, progesterone, and prolactin are the ones which synergetically act on the breast to be enlarged, but there will be no milk production until delivery. So after delivery, the milk production is possible because of the removal of the negative impact of the progesterone, which is progesterone and estrogen, which are inhibiting milk production during the time of pregnancy. So how is milk production takes place? How is the milk production and ejection is controlled hormonally? This shows us that the suckling of a baby has a kind of mechanical stimulation to the neural hypothalamus neurons. So these hypothalamus neurons are producing, so prolactin releasing factors into the plasma, and that leads to action on the pituitary, anterior pituitary, for increasing prolactin secretion. The prolactin is a hormone which is very important to act on the breast to stimulate the gland cells to produce the milk, to initiate milk production or in milk synthesis. So plus prolactin is important for milk production. On the other side, oxytocin will be produced from, because of the suckling of the baby, oxytocin is produced from the posterior pituitary, and increase in oxytocin acts on the breast to have a kind of contraction of the myoepithelial cells in the breast, so that milk ejection is possible. That means the milk will be ejected, and that is the way how it will be happening. So this is just to see that increase in oxytocin increase the contraction, so that it will affect the milk ejection. Increase in prolactin is affecting the breast gland cells to produce more milk during after parturition. So these are all what we have for today, and tomorrow we will have a kind of revision for your preparation for the exam, and I think you will be good to go for next week exam after revising tomorrow the whole exam questions. Okay, thank you so much and have a good day.